So, ladies and gentlemen, welcome back. This is an extra ground round from our association. Today, we have a guest speaker due to this corona COVID-19, basically a SARS coronavirus that is spreading all over the world. And we decided to put an extra ground round, an educational ground round, to talk about the update about this whole situation that is spreading all over the world. And due to this, today we have a guest speaker from Atlanta, the Assistant Professor Jordan Kaylor. Good morning, Jordan.
Good morning.
So today, Jordan is going to talk about some news about the COVID-19. In December 2019, a new cluster of pneumonia cases was reported in Wuhan, in the province of China. And epidemiologically, it was linked to a seafood wholesale market in Wuhan area. And this novel coronavirus is belonging to a family of viruses that cause a severe respiratory syndrome, which is called also SARS, and also Middle East respiratory syndrome, as well as the 4 human coronaviruses that are associated with the common cold. And then were subsequently isolated from the lower respiratory tract samples of 4 cases on 7 January 2020. And then the whole thing became huge. And the World Health Organization declared that the SARS-CoV-2 outbreak constituted a public health emergency of international concern. And more than 80,000 confirmed cases has been reported worldwide of 28 February 2020. But now we are facing new things going on. And the situation is totally confirmed at 464,000 cases. This is just an update that became at 3:33 p.m. area. For anyone interested, there's a site that you should go and check, which is type gisaid.org. So after that, I will lead the torch to Kaylor. Please go ahead with your presentation.
So thanks again for inviting me. I'm Jordan Kaylor. I'm an emergency physician in Atlanta, Georgia, in the United States. Again, I appreciate the opportunity to address everyone. I have no conflicts of interest to declare for this talk. Just a little bit about myself. I did residency in Chicago, Illinois at Northwestern Memorial Hospital. I currently work at Emory University Hospital, Midtown, which is an academic tertiary care hospital in Atlanta, Georgia. We see 60,000 to 70,000 visits per year just in our emergency department. We're also a little bit unique because we receive any traveler who's identified as high risk of having a highly communicable disease. We receive those travelers directly from Hartsfield-Jackson Atlanta International Airport. They come directly to our emergency department for screening and risk stratification. And we're also the primary clinical site for Emory otorhinolaryngology. So a little bit of background about the virus. It's a novel beta coronavirus that's related to SARS and MERS. In fact, it was initially called, it's called severe acute respiratory syndrome coronavirus 2, and was given the shorter name COVID-19 in December of 2019. But it's already surpassed the death toll of SARS and MERS combined, so it certainly has a larger global impact. This was from a recent New England Journal of Medicine article just describing where the cases were located in China. And this is some of the first good data that we have about the symptoms of coronavirus among patients in China. They published, I think, 1,099 patients. They published information about the symptoms that they presented with, their comorbidities, and their illness severity. And this is just showing where those patients were from in China. So the clinical features of the virus, it seems to have an incubation period of around 4 days, as long as 14 days from exposure until symptom onset. But the majority of patients develop symptoms within 4 days of exposure to an infected patient. And the majority of patients who develop symptoms develop symptoms that are not severe. About 80% of cases are not severe, 20% of cases from this China cohort were severe. The majority of them had chest radiographic abnormalities, either on chest x-ray or CT. So 82.1% of patients who presented in China with non-severe disease had chest radiographic abnormalities. 97.1% of patients with severe disease had radiographic abnormalities on chest imaging. The number one symptom among all patients was fever, but interestingly, only 43.8% of patients had fever when they initially presented to the hospitals in China. So it is possible to see these patients presenting without fever initially. In fact, less than half of the patients in China presented without a fever, but 88.7% of them went on to develop fever during their hospitalization. The second most common symptom has been cough. 67.8% of patients in China with confirmed COVID-19 had a cough. And it's important to note that GI symptoms, gastrointestinal symptoms, are relatively uncommon in these patients. It primarily seems to cause a viral pneumonia type picture. So fever, cough, and shortness of breath are going to be the primary symptoms. Much less common are gastrointestinal symptoms. It seems to be transmitted by respiratory droplets among close contacts, and close contacts we consider to be people who you've been within 6 feet of for a prolonged period of time. The droplets do not seem to linger in the air that long, and it seems to be transmitted through infectious secretions, sputum, serum, blood, or respiratory droplets. The laboratory features, the most common laboratory abnormalities that were seen in these patients in China with confirmed COVID-19 were lymphocytopenia, so low lymphocyte counts, thrombocytopenia, and leukocytopenia were seen in about a third of patients. But the primary the most common lab abnormality was lymphopenia. This is demonstrating the ages of the affected patients in China. It seemed to affect people ages 15 to 49 years old most. But if you look at the patients who had more severe disease, the majority of patients with more severe disease, which they defined as patients requiring mechanical ventilation, patients requiring admission to the intensive care unit, or patients who died, the most severe disease seemed to affect the elderly patients, those greater than 65 years old. Young patients, those 0 to 14 years old, seemed relatively unaffected and seemed to have very mild symptoms. So the disease seems to primarily affect older patients. And again, the most common symptoms seen in the patients in China with confirmed COVID-19 were cough, sputum production, and fatigue. So it seems to cause a sort of viral pneumonia type picture. And those who tended to have worse outcomes, those requiring mechanical ventilation, ICU admission, or those who died, this is showing the comorbid conditions that they had. The most common comorbid conditions were hypertension and diabetes. So patients with comorbid conditions and patients who are older tended to have worse outcomes. Although among all the patients in China, poor outcomes were relatively rare. Only 5% required ICU admission. Only 2.3% underwent invasive mechanical ventilation, and only 1.4% died. But this New England Journal of Medicine study looked at only patients who sought medical care who then had laboratory confirmed cases of COVID-19. So it's hard to extrapolate how bad outcomes are of all comers because they didn't test patients who didn't present to the hospital, and they didn't test patients with mild symptoms who did not present to a healthcare system. So it's likely that the real world case fatality rate is actually a lot lower than what they're presenting in this data. So the guidelines in the United States, at least, about who to test for the virus vary by the hour and by the day. But as of March 4th, 2020, our Centers for Disease Control and Prevention recommends that we test anyone in whom we have a high clinical suspicion for COVID-19. And that's primarily patients who have a fever with acute respiratory illness. They also recommend testing those who have had close contact with a laboratory confirmed case of COVID-19 within the last 14 days, or for patients who, this is kind of an older recommendation, but patients who traveled to affected geographic regions within the last 14 days, and within 14 days of symptom onset. And as of February 28th, they were considering areas with high disease prevalence to be China, Iran, Italy, South Korea, and Japan. But the map that I've pasted below is from the CDC website yesterday. Those are countries with confirmed cases of COVID-19. So it's becoming more and more widespread every day. And I think we're going to start testing more and more patients for it. In terms of testing, we recommend testing with viral nucleic acid real-time PCR testing. The CDC recommends that we collect nasopharyngeal and oropharyngeal swabs, and if possible, if the patient's intubated, collecting a lower respiratory tract sample. And the chart on the right here is from a New England Journal of Medicine article, essentially showing how the viral load and viral shedding decreases with time since symptom onset. So the later you sample patients, the lower the viral load is going to be. There's some evidence that imaging is actually a more sensitive way to test for COVID-19 than the real-time PCR. The real-time PCR seems to only have a sensitivity of around 71%, whereas non-contrast chest CT may have a higher sensitivity for detecting viral pneumonia, based on data out of China. So I ran across this article yesterday, but they had 81 patients who presented to a medical center in China who were eventually diagnosed with COVID-19. And of 51 patients who had an initial chest CT, non-contrast chest CT, and initial real-time PCR, 15 of those 51 patients initially had a negative real-time PCR for COVID-19, but had a chest CT demonstrating viral pneumonia. So that suggested that if you were to test patients when they initially present to the emergency department, you may be able to detect up to 30% more cases by getting a non-contrast chest CT than you would by real-time PCR. It also suggests that the nasopharyngeal and oropharyngeal swabs might miss up to 30% of cases, and that patients might require serial testing. So if you test them with real-time PCR and their initial test is negative, it doesn't necessarily rule out COVID-19. If you were to test them a day or 2 or 3 days later, they may actually test positive. So a negative test does not rule out disease. And these are some examples of radiographic imaging findings of patients with non-severe versus severe disease. It essentially looks like a viral pneumonia on chest CT and on chest X-ray. So I wish that there were more specific treatment recommendations, but right now the treatment recommendations per the World Health Organization are essentially just routine care, providing supplemental oxygen, non-invasive ventilation, or mechanical ventilation if indicated. They recommend adding antibiotics to cover suspected bacterial pathogens. So in the case of a multifocal pneumonia, it would be reasonable to cover with antibiotics, even if it's suspected to be viral. And then IV fluid and IV fluid resuscitation if indicated. Unfortunately, there's not any specific COVID-19 treatment at this time, although as I'll talk about in a second, there are some theoretical treatments that may be a benefit, but there's certainly not evidence to suggest widespread use of any specific treatment. So there's some thought that an antiviral medication called remdesivir may show some in vitro and in vivo activity in animal models against COVID-19. There is also some case studies out of China where they tried a combination antiviral medication that's typically used for HIV treatment called Kalytra. Kalytra is the brand name that may show efficacy down the road. I would definitely recommend against using glucocorticoids in patients with COVID-19. There's some suggestion based on MERS and SARS experiences that these may actually worsen outcomes. And there's also thought that down the road, angiotensin receptor blockers may be a potential therapy for patients with COVID-19, although this is based sort of on speculation and previous experience. And because this is such a new disease, we don't have any definitive data to suggest treating patients with these. Probably most important is protecting ourselves so that we as healthcare workers do not become infected. Because coronavirus seems to be transmitted primarily by respiratory droplets, these recommendations are changing every day, even for us, but it's important to use standard precautions, gloves, and hand hygiene. We are also currently recommending using contact precautions, both wearing a gown and wearing eye protection. And as of yesterday, the CDC had recommended that we also use airborne precautions when we care for these patients, which here means using an N95 or a capper, and also placing patients in a negative pressure room. Although I think that they are updating their guidelines to no longer recommend that. It seems like just gown, eye protection, gloves, and hand hygiene will be sufficient, as well as just a standard procedure mask. And I think that they're going to stop recommending N95s or cappers or negative airflow because the virus seems to be, we seem to be sufficiently protected just wearing procedure masks. And with the exception of when an aerosol generating procedure is being done, it's still being recommended that anytime aerosol generating procedures are being done, that we wear either an N95 or a capper and perform these in a negative airflow room. And those would include CPR, bronchoscopy, deep suctioning. But ultimately, it's important to remember that this is a very new illness. We don't have a whole lot of data to guide treatment. A lot of what we're doing now is primarily supportive care. We certainly need more studies in order to guide future treatment, but it's just such a new process that we don't have a lot of information to guide therapy at this point. And in summary, kind of the basics are the best we can do to prevent transmission of illness. So avoiding close contact with people who are sick, covering our nose when sneezing, avoid touching your eyes, your nose, your mouth, cleaning and disinfecting frequently touched objects and surfaces. And just as an aside, it seems that the cleaning wipes that we use in the hospital routinely are effective against COVID-19. So just the disinfectant wipes that we stock routinely or bleach wipes seem to be effective at killing the virus. And then remembering to stay home when we're sick and washing hands often or using an alcohol-based hand cleanser seems to be effective. So again, the primary symptoms seem to be a viral pneumonia, so fever plus respiratory symptoms. The majority of these patients will have abnormal either chest x-rays or non-contrast chest CTs. It seems to be spread primarily in respiratory droplets. There's not any specific treatment aside from routine care, although treatments may be available down the road as we have more evidence. And then most importantly, protect yourself both with appropriate contact droplet precautions and eye protection, and then practice good hand hygiene. So I think that's all I have. I thought that would take a little bit longer.
Don't worry, it's very good because we might have some time for questions, but before that, I would like to analyze a few things with you, which basically are in of your interest. Do you have anything at the moment available as a schematic procedure in Atlanta or the surrounding area that will guide you to a proper way to diagnose those patients? For example, over here in Italy, we basically build outside of the hospital a pre-admissions. So we are facing the problem and we are trying to facing the problem before entering into the hospital. And the main mistakes was exactly this, where the people at the beginning of the disease were just coming inside of the hospital, and that will lead to spreading of the infection. So do you have currently anyone or any address that would guide you to what to do or not to do?
Right now, we've not implemented a process yet, but our goal is to place a physician right by our door to screen patients as soon as they walk in our front door. And those who look well, who are well appearing, who have fever and cough, we hope to be able to hand them paper discharge paperwork and discharge them right from the door so that they don't even come into the waiting room. So, and the hope is to minimize transmission. I have heard of some hospitals actually using drive-throughs where people can drive up to a booth where they're screened by a physician, and that physician can test them for COVID-19 and then can send them back home awaiting results. Because it does seem to be a problem. I think I read that in China, 40-something% of cases were acquired in healthcare facilities by transmission, either among patients or from a patient to a healthcare worker and back to other patients. I would not say that we've rolled out anything at our hospital yet, but I think within the next few days we will.
Okay, and what was the role of the GP in this whole thing situation? Do you think that a role of the GP right now is to addressing patients to a proper way, or do they have to admit the patient and then see what's going on?
I think the more that they can do from their office, the better, because the more sick patients who come to the emergency room, the more we're going to have disease transmission in the emergency room. And from what I've seen, GPs have done a good job of triaging patients over the phone. And if their symptoms are not severe, they've encouraged them just to stay home and not even to come in for an evaluation. I think that will definitely help decrease transmission. But I think, unfortunately, a lot of patients here do not have primary care doctors. But among patients who do have primary care doctors, I think the GP plays a big role in keeping not very ill patients from coming to the hospital.
Right.
And I think the majority of these patients will not require hospital admission. So I think a lot of this triage can be done either by phone or in the primary care doctor's office. And if they identify a patient in their office who's sick, they can call us ahead of time to let us know the patient is coming. And that way we can isolate that patient and ensure that everyone is using appropriate precautions with that patient, which may decrease disease spread.
Okay. I was recently reading a new, not a new post, basically from one of your colleagues from Emory University. One of our colleagues, she's an ENT surgeon and rhinologist, is a friend of ours, is Zara Potter. She were actually sharing a few excellent articles, which is not very new. Some of them are from 2015, and it seems that we basically were not new with these whole things, because there were some this article from 2015 was introducing a SARS-like cluster of circulating bad coronaviruses that pose threat for a human emergence. And it looks like in that paper, the people and these colleagues were actually already telling that it seems something that is going to happen. And do you think that the literature was guiding us to be more, in alert?
I think so. And fortunately, at Emory, we have a team who has been prepared to receive patients with Ebola from the airport and from other countries. So, and that team has practiced and developed policies and procedures for caring for patients with severe communicable diseases. But I don't think that we realized that this could happen very quickly and could affect a larger number of patients. I think they're primarily prepared to receive one or two patients from other countries with advanced notice. And this is posing an issue on a much larger scale. So I think that I think the literature suggesting that several years ago was right. And maybe we aren't as prepared as we should be.
Just to end this whole short meeting, which it was great anyway, because there's lack of time. However, you did a brilliant presentation with data which are essential for our research and our teaching activities. I would like to spread and to put some attention to this slide right here. So this is the whole situation around the world. We have total confirmed case are 121,000, which are 80,000 in China. Today, they announced that they are leading to stopping the whole virus spread. And then we have 10,000 cases in Italy, basically, and 9,000 in Iran, which was a switch. As you remember, Iran came as a second position, and right now came to a third position. Would you have any kind of hypothesis for that?
I don't know.
And that's sometimes we have to say that we don't know in order to provide much more studies. And right now the thing is that we have to focus on what's going on and to reach to China and to see what's happening, because what the total death, as you can see over here, looks like 4,300 people are dead, and the total amounts of recovery are 67,000. Before closing, we do have a questions that we'd like to address. Unfortunately, as I said, there's some troubles with the peer-to-peer and Zoom application and sharing experience. One of our colleagues is asking, can you mention the main cause of death in the confirmed cases of corona? I think that you cannot. They're not a main cause. There are different one. And the other question is there other complication rather than pneumonia, like meningitis or myocarditis?
So based on the data I've seen, it seems to primarily affect the lungs, and I think the complications are primarily related to pneumonia progressing to ARDS, hypoxemic respiratory failure that's refractory to mechanical ventilation. I've not seen other specific complications like meningitis or myocarditis, but I think part of that is just we have a small sample size and we don't really know yet. I mean, the data from the patients in China was just published, I think, in February, and I think that was the first cohort of patients who we have descriptive data about to even know what symptoms they had and what complications they developed. So I've only seen data on, I think, 1,095 patients with confirmed COVID-19 from China, and I think we just don't really know yet what other complications are possible.
Perfect. Thank you, Kaylor. So it's time to say that we need more attention to what is going to change in the next few days, and I do believe that it's essential to make more attention to this situation right now. And I do think that I would like to invite you in the next few weeks to see what's going on the situation in the United States. If you do have any news about that, we will be glad for that.
Sure. Just let me know.
Perfect. Thank you so much for being with us today. And
thank you, Jordan.
And
thank you.
And thank you again. And I see you for the next few weeks. Goodbye.
Bye-bye.
Thanks. I'll disconnect.